Hi everyone, welcome to Dr. Deepa's Learning Launch. Hope you are enjoying my content every day. Don't forget to like, subscribe, and share my content. In this session, we will walk you through the morphology of red blood cells in a structured way. In this lecture, I will begin with how the normal erythrocyte looks like on the peripheral smear and then move on systematically through the alterations of the size, hemoglobin content, the shape, and the inclusions. And finally, we will see how these changes translate into clinical diagnosis. This is essentially the morphological language that a pathologist used to interpret the blood films. By the end of this talk, you should be confident in using the terminology of red cell morphology correctly. You should be able to look at the smear and say not only that there is anemia, but also whether it is normocytic, normochromic, microcytic, hypochromic, or with any other abnormal cell. You will also be able to emphasize on the practical significance of each pattern. What is the physiological variant and when should you be alarmed? A typical normal red blood cell is a discocyte, which is a biconcave disc. On a well-made peripheral smear in a monolayered zone, it appears round with a central pallor area occupying one-third of the diameter. The average size is roughly 7 to 7.5 microns. In a healthy adult, the RBC population will show a slight variation in the size and the shape, and this boring uniformity is usually a good sign. This is a scanning electron microscope image of how the RBC looks like. You are able to see that there is a central pallor in one-third of the RBC and the rest of the two-thirds is filled with hemoglobin. And this is what it looks like in the unilayered area of the peripheral smear. The shape and deformability of the RBC is governed by the underlying membrane skeleton. Spectrin forms the backbone of the entire RBC, where alpha and beta chains assemble into tetramers that link into a meshwork. This meshwork is anchored to the lipid bilayer mainly via two complexes, one involving the ankyrin and band 3 and another involving the actin, protein 4.1 and glycophorin C. Proteins like protein 4.2 and adductin fine-tune these interactions. Any inherited or acquired defect in these proteins can produce a characteristic cell shape abnormality, which is why understanding the architecture is very, very important. So this is a picture of what I just spoke about. Here is the spectrin, which is the membrane cytoskeleton, which forms the spine of this whole molecule. And band 3 and glycophorin C is one unit. And ankyrin band 3 is the second unit. As you can see, the defect in this unit leads to hereditary spherocytosis. The defect in tetramerization domain leads to elliptocytosis or pyropoikilocytosis. A defect in the other molecules like PAE, ZO1, KCNN4 causes dehydrated hereditary stomatocytosis. So depending on which area of the RBC is involved, there is a different morphology that sets in. Normocytic and normochromic sound straightforward but must always be interpreted in a context. A neonate's red cells are physiologically larger than the adult cell, and calling them macrocytic is wrong. So any mild variation that is there in pregnancy also is physiological. So each lab decides whether to write normocytic normochromic on a normal film or comment only when something is abnormal. The key is the consistency of normocytic normochromic that is very helpful in following up with a differential. So the exceptions of having a slightly bigger cell in a neonate or some amount of mild physiological changes in pregnancy should not be misinterpreted as macrocytic or any abnormal shape. Anisocytosis simply means increased size variability. On the analyzer, this corresponds to an increased RDW. It is very non-specific finding, and you'll see it in iron deficiency, megaloblastic anemia, hemolytic states, mixed deficiency states, etc. The key is do not label physiological situations like neonates and pregnancy as anisocytosis, and the pattern should be appropriate for age and state. Using this term only when variation reflects a pathology is congenial. Microcytosis is a morphological terminology when the RBCs appear smaller. The size of the lymphocyte nucleus is your built-in stage micrometer. If any cell is smaller than the nucleus of a small lymphocyte, then it is considered to be microcytic. If most cells are small, then the MCV falls. But if only a small subpopulation is small, then the MCV may remain within the normal range, but you cannot totally rely only on the MCV. You have to look at the lead cell distribution width also. Also, be cautious not to misinterpret red cell fragments in any conditions like hereditary pyropoikilocytosis or mechanical hemolysis as a true microcyte. This is an image where you're able to see these very small sized cells. So this is a classical picture of a microcytic hypochromic anemia. The age and the ethnicity matter. Healthy children usually have a slightly smaller RBC than the adult. Neonates, on the other hand, have larger RBCs, macrocytic red cells physiologically. So, microcytosis in a newborn is unusual and should alert anything like alpha thalassemia, intrauterine iron loss, congenital sideroblastic anemia, or any iron handling defects. In some ethnic groups, particularly in populations with high prevalence of alpha thalassemia, or certain hemoglobin variant, the average MCV tends to be lower. So these will help in the population study also. First, let's look at the inherited causes of microcytosis. Among the inherited causes of microcytosis, thalassemias dominate. Beta thalassemia trait shows marked microcytosis with relatively preserved hemoglobin. There is classically an erythrocytosis and a reduced Menzer index. Homozygous or compound heterozygous beta thal states and HPH disease show even more dramatic changes. Many structural hemoglobins have functionally like thalassemias produce microcytosis. Example includes HBE, HB Lepore, certain elongated and unstable alpha variants like constant spring, congenital sideroblastic anemias, rare defects of iron metabolism, and these can also cause profound microcytosis. The acquired causes of microcytosis most often is due to iron deficiency. Anemia and chronic states also can become microcytosis later on, and normocytic is more typical. Myelodysplastic syndrome, especially those with ring sideroblast and acquired HBH disease, can show microcytosis. Secondary sideroblastic anemia is classic cause. Drugs, alcohol, lead, copper deficiency, zinc deficiency, and some porphyrias can all distribute and disturb the iron utilization. Hyperthyroidism, cadmium, aluminum toxicity, and other rarer mechanisms also can produce microcytosis. Macrocytosis refers to a larger than normal RBCs. Again, remember age and physiological state. Newborns and fetuses have large red cells, and mild macrocytosis is common in pregnancy and elderly populations. On smear, macrocytes can be round to oval. They can be oval macroovalocyte, especially that is important in megaloblastic anemias and certain dyserythropoietic states. Macrocytosis may involve all red blood cells or only a subpopulation. In the subpopulation, the MCV may not fully reflect the actual morphological change. This is a picture of macrocytic anemia in which there are so many macroovelocytes. They are nearly the size of a neutrophil in this case. One major mechanism of macrocytosis is reticulocytosis. Reticulocytes are naturally larger than mature red cells, so any vigorous marrow response such as hemolysis, acute hemorrhage, or marked hypoxia can raise the MCV and red cell distribution width. The classic macrocytosis is called megaloblastic, in which the B12 or folate deficiency leads to increased RBC size. These lead to defective DNA synthesis, nuclear cytoplasmic asynchrony, macroovelocytes can be seen. Many cytotoxic and immunosuppressive agents, antiretrovirals, antifolate drugs can be producing the similar picture. Rare inherited enzyme defects in nucleotide metabolism can fall into this group, which is congenital megaloblastic anemia. Macrocytosis has a long list of conditions because there is a classic megaloblastic bone marrow morphology. Myelodysplastic syndromes and some AMLs often present with macrocytosis even before the obvious cytopenias. Alcohol is another very common cause which can be overlooked. Hydroxyurea therapy and some newer targeted agents can also cause macrocytosis. A range of congenital marrow failure syndromes and mitochondrial disorders present with macrocytic RBCs. Finally, remember that artifacts, cold agglutinins, or delayed sample analysis also can falsely increase the MCV. Hypochromia refers to a less hemoglobinization per cell visually. Central pallor exceeds beyond its usual one-third. It is often but not always associated with microcytosis. In some alpha and beta thalassemia traits, you can have a striking microcytosis with a relatively modest hypochromia, not very prominent. Thin plate-like cells, which are called leptocytes, also can appear in hypochromic states simply because of altered geometry. Hyperchromasia is less commonly a word used, and architecturally hyperchromatic cells are spirocytes. and irregular contracted cells with an increased MCHC. It's better to specify the cell type rather than using the term hyperchromasia, so it is rarely used by the pathologists. On your left is a blood film that is showing hypochromic red cells in a patient with iron deficiency. You can also notice that there is anisochromasia. There are some polychromatophils here. On the right is a dimorphic blood picture in which you have these microcytes and pencil cells along with these large macroovelocytes. So both types of morphology are there. And this is a stomatocyte. Anisochromasia tells you that the hemoglobin content is not uniform among all red cells. Some cells are pale while others are normal. It often signals to a changing iron or inflammatory status, either onset or recovery from it. Dimorphism is even more striking. Two populations usually appear clinically separate in size and hemoglobin content. Think of it as a patient with iron deficiency who has just been transfused or started with iron. The old microcytic cells remain, plus a new set of normocytic cells will appear. So you have anisochromasia and anisocytosis. In sideroblastic anemia, you may see hypochromic microcytes plus a normochromic cell. Double deficiency or post-treatment states commonly create this dimorphic pattern. Polychromasia is a bluish tint RBC which are slightly larger because of their immaturity. Romanowski stain picks up both hemoglobin and residual RNA. Therefore, you will be able to visualize a polychromatophil in Romanowski type of stains. These are reticulocytes on their way of becoming mature RBCs. Not all reticulocytes look polychromatic, only the earliest forms look polychromatic. So the reticulocyte count is usually higher than the visible polychromasia in most of the cases. That is very important to remember. That is also a quality check. In case you have a Leishman stain in which you have, let's say, 2% polychromatophils, but on your retic stain you are able to see only less than 1%, it means there is some staining error that has happened on the technical side. In hemolytic anemia or blood loss, the polychromatophil should be very prominent. If an anemic patient has no polychromasia, it means that the treatment is not working for the patient. It's a red flag of pure red cell aplasia, aplastic anemia, anemia of chronic disease, or poor EPO response, or a parvovirus B19 induced aplasia, or some sickle cell disease type of a pattern. So anytime that you don't find polychromatophil after a treatment for anemia or blood loss, it is a definite red flag. This is a peripheral smear in which you are able to see these nucleated red cells. Along with this, you are seeing these macrocytes and macroovelocytes along with microcytes, some fragmented red cells, and these are the polychromatophils which appear somewhat bluish compared to the regular RBCs. Poikilocytosis is a shape disorder. Mild poikilocytosis is common in many anemias, but a striking poikilocytosis can occur in other conditions such as myelofibrosis, severe dyserythropoietic states, hereditary pyropoikilocytosis, hemoglobin H disease, etc. Always confirm that you are seeing this truly and the RBC shape abnormality is not an artifact due to cryoglobulin precipitation that can inadvertently happen in case of long storage. This can mimic pyropoikilocytosis or poikilocytosis. On your left is the blood film of poikilocytosis in a patient with hereditary pyropoikilocytosis. You are able to see so many different shapes in this picture. On the right is a blood film again with poikilocytosis in a patient who has co-inherited elliptocytosis and hemoglobin H disease. So these are the classical elliptocytes that you're able to see here. Spirocytes are classical for hereditary spherocytosis and warm autoimmune hemolytic anemia. They are dense and round, lacking the central pallor, and with increased osmotic fragility and often increased MCHC. The underlying mechanism is a membrane loss, often by a splenic macrophage nibbling off the antibody coated RBC or direct membrane damage by heat, toxins, or trauma. Smaller number of spirocytes are common in microangiopathic hemolytic anemia, mechanical hemolysis, some hereditary pyropoikilocytosis states, and stored blood. It's critical to distinguish a stored blood spirocyte from irregularly contacted cells due to diagnostic implications. This is a blood film of a patient who has underwent burns, and these are the spirocytes that you're able to. So they are sort of rounded off. The microspirocytes are red cells that appear to be budding off. Very small spirocytic fragments are also seen here and there, which are snipped off by the splenic arterioles. Not very similarly, there is an artifact that is produced by in vitro heating also. Irregularly contracted red cells are a hallmark of an oxidative injury. In G6PD deficiency or unstable hemoglobins, the hemoglobin precipitates as Heinz bodies. Splenic macrophages spit out these inclusions, taking some amount of membrane along with them and leaving behind a dense, irregularly shaped body. Ghost cells, hemighosts, keratocytes are usually an accompanying pattern. Recognizing this combination of irregularly contracted cells with Heinz bodies and bite cells is very helpful in diagnosing an oxidant hemolysis. This is a scanning electron microscopic picture of a hemighost cell. This is where the Heinz body was bitten off by the spleen. This is another similar picture in the peripheral blood. The picture on the right is a transmission electron microscopy of the same Heinz body containing hemighost cell. Elliptocytosis and ovalocytosis are defined morphometrically. When they dominate in the smear, think of hereditary elliptocytosis or Southeast Asian ovalocytosis. And if they are very low in quantity, it can occur even in inherited cytoskeletal defects like spectrin 4.1 protein, band 3 glycophorin C also can get affected. Smaller number of elliptocytes can reflect some amount of dyserythropoiesis like in iron deficiency, thalassemias, MDS, megaloblastic anemia also. Macrovalocytes are a classic teaching point of megaloblastic anemia. This is a picture of hereditary elliptocytosis where you're seeing these elliptocytes along with these ovalocytes. The ovalocytes pretty much resemble the ones that we see in megaloblastic anemia, but this accompanying elliptocytes are classical of a hereditary event. Teardrop cells should always prompt you to find out if there is a marrow fibrosis or severe dyserythropoiesis. In primary myelofibrosis and in metastatic infiltration, teardrop cells are a key feature and often accompany a leukoerythroblastic type of a picture. They also occur in thalassemia major, megaloblastic anemia, etc. Splenectomy may reduce their number, and in some conditions, this supports the role of splenic shaping of the abnormal RBC. This is a PMF picture, and this is what a teardrop cell looks like, pretty much like a drop of water that is coming down. Some older terms like spiculated cells are confusing. The BESIS classification is based on the careful electron microscopy and how much more precise we can be. Well, the use of echinocytes, acanthocytes, keratocytes, cystocytes, and vague terms like Burr cells are used by many pathologists. Such subtypes have different pathophysiological mechanisms and disease associations, and they don't essentially mean the same. Echinocyte is the name that is suggested for an RBC on its resemblance to a sea urchin. So it basically has regular short spikes. The most common cause is that technically the smear is made late from an EDTA anticoagulated blood. So always judge an echinosis in the context of a fresh sample only. Physiological echinocytosis is seen in renal failure, severe hepatic and multi-organ failures, and sometimes the enzyme deficiency like pyruvate kinase deficiency. It can also appear in critically ill patients after severe burns, hypothermia, bypass, or certain drug exposures. So always comment on echinocytes only if you're sure that the patient sample is fresh, and also you can intrigue into the clinical aspects which I have just mentioned. This is the peripheral blood of a patient with chronic kidney disease. You're able to see these short stubby echinocytes which resemble sea urchin. Also, you have scanning electron microscope image of the echinocyte. This is what it looks like in the scanning electron microscope. Unlike echinocyte, acanthocytes are irregular and often have bulbous projections and do not form a rouleau. They are classically seen in A beta lipoproteinemia related lipid disorders within the RBC membrane. Cholesterol lipid ratio is altered. The sparsel anemia of advanced liver disease is an important acquired cause that often signifies a poor prognosis. Neuroacanthocytosis syndromes can sometimes present with neurological symptoms plus acanthocytes in the peripheral blood. Post-splenectomy, small numbers of acanthocytes are also common. This is a blood film from a patient of having anorexia nervosa. So you can see this is an acanthocyte where you have irregular, long, bulbous looking projections from the RBC. Next is the scanning electron microscopy image of a similar acanthocyte. Keratocytes and cystiocytes are the next what we are going to discuss. The keratocyte are horned cells. They often form when the membrane folds and ruptures, leaving about 3 to 4 spikes, which are longer than the ones which we discussed. They're typically due to mechanical damage like fibrous strands, prosthetic valves, microangiopathic processes, and after pitting of the Heinz bodies. Cystiocytes are true fragments. These are central for diagnosing thromboangiopathic microangiopathies and mechanical hemolysis. In ICSH guidelines, there it is also recommended to have how much percentage of them are seen in the peripheral blood. Anything more than 1% of cystiocytes should be called as a significant abnormality. These are the keratocytes in the blood film of a patient with microangiopathic hemolytic anemia, and this is the scanning electron microscopy image of the same. Target cells form when there is more membrane than the cytoplasm. So that part folds in into a central drop like thing. So when cytoplasmic volume shrinks disproportionately, you produce target cells. The liver cells with altered lipids cause membrane to expand. And in thalassemia and iron deficiency, the main issue is low hemoglobin content. So both in these two, you can have target cells. Kinzocytes are triconcave cells that are less commonly reported but is associated with certain liver and inherited conditions. So it's a triconcave RBC. It can also be seen in congenital form in Southeast Asian ovalocytosis. The next is stomatocytes. Stomas mean mouth. So stomatocyte is mouth-like with a central pallor. Alcohol and alcoholic liver disease are common acquired causes. Inherited stomatocytosis and xerocytosis are rare membrane channel disorders that often cause hemolysis, altered hydration of the RBCs, and production of stomatocytes. So this is what is a target cell. Just like the bullseye in the center, you're able to see the blobby, long cell membrane that folds inwards towards the pallor area. So you have a spot-like thing in the middle. So this is classical of a target cell, and this is the electron microscopic picture of the same, where you're able to see that the membrane is bigger than the cytoplasm, so it has just caved in. The same thing when you're staining, you are able to see it as a central dot. A true sickle cell is pathognomonic of a sickle cell disease and not trait. You may see elongated boat-shaped cells which are peculiar poikilocytes in hemoglobin S when it coexists with hemoglobin C or other variants also. Pincer cell or mushroom-shaped cells are interesting and very less common. They're typically associated with specific membrane protein like band 3 deficiency and certain dyserythropoietic hemolytic anemias, including red cell damage in infections of COVID-19. So we did see a lot of mushroom cells in COVID-19 infection, and this was reported in many of our reports as well. Here you are able to see the peripheral blood image in which you are able to see this nucleated RBC. There's so much of anisopoikilocytosis, and this is a classic sickle cell in the peripheral blood. You're able to see the same thing in the electron micrograph of a scanning electron microscopy also. It shows the classical sickle type of shape. Some complex metabolic and inflammatory states such as metabolic syndrome, dyslipidemias, PCOS can also see a mixture of spiculated cells like acanthocytes, echinocytes, and stomatocytes. The underlying mechanism includes some oxidative stress of altered membrane lipids. These changes are non-specific but remind us that the RBC morphology almost reflects the whole body's metabolic health, and it can be temporary based on the symptomatology of the patient. This is the peripheral blood picture of stomatocytosis. You are able to see this mouth-like gaps in the RBC. This is a scanning electron microscopy image of the same. Well, before we close today's session, I wanted to take a moment and appreciate something simple yet very extraordinary. A humble red blood cell. What looks like a small disc on the microscope is actually a storyteller. Every shape, every size, every color, and every membrane irregularity is a soft clue to an underlying disease process. So let's continue tomorrow discussing RBC inclusions. This is Dr. Deepa signing off today. Please don't forget to like, subscribe, and share my videos. It is your like, your subscriptions, and your feedback that drives me to teach you more every day.